Good afternoon, everyone, and thank you for joining us for today's webinar. My name is Rachel Logan, the Training and Technical Assistance Manager at the National Center for Health and Public Housing. We are joined today by Zara Marcellian, the CEO of LaMaistra Community Health Centers, and Dr. John Queck, who is a health education psychologist and works also at the health center, and he's also a minister. So today, after today's webinar, attendees will be able to identify reasons for enhancing services at their health centers with cultural and linguistic competency through collaborations with ethnic and faith-based organizations. Attendees will also be able to understand the steps to identify and cultivate collaborations with ethnic and faith-based organizations and identify roles to be performed by the staff or other members of the ethnic and faith-based organizations as well as health center staff. At the National Center for Health and Public Housing, we work with health center programs who are funded by HRSA to provide quality care to low-income and special populations, specifically residents of public housing. We do this in various ways, including an example, today's webinar, as well as training, manuals, toolkits, and other materials. The reason that we decided or selected this particular topic is because understanding faith-based organizations and the role that they play in communities is important to reaching your special populations. A lot of times, faith-based organizations will represent a form of unity in the community, and it's important for health centers to be a part of that conversation, of that organization, and serve a crucial role. I would like to remind all attendees that today's webinar will be recorded and made available to you following the webinar, as well as posted to our website. So before I turn the the presentation over to Zara, I would just like to read their bios very briefly. Zara has a master's degree in organizational management and has been actively involved in healthcare, education, community organizations, and other nonprofits for over 25 years. She specializes in services to underserved immigrant, refugee, and other low-income residents in the inner city of San Diego. Zara has also been recognized locally and nationally as an ambitious advocate for the cause of helping the underserved and developing innovative models to improve access to culturally competent health and social services. Dr. John Queck grew up in a village in southern Sudan and lived in 3 different refugee camps during the 1980s and 90s and arrived in the U.S. shortly after. He worked as a healthcare interpreter in refugee camps and later worked full-time counseling refugees and underserved families at health centers. He continued his education while working at LaMaistra and earned his PhD in psychology in 2013. He currently is a minister at the College Center Covenant Church and is continuing his work at LaMaistra. So Zara, I will go ahead and turn the presentation over to you.
Well, thank you very much. Good morning to us. Good afternoon for most of you. I would also like to point out at this time that I have here Elena Cruz. She's a program director of our senior peer promotora programs. She is coordinating and has been for the longest time the health education out in the community, in the public housing, low-income housing units, working with managers, the tenants, and so forth. So she's going to be talking about how that effort is very, it has a lot to do with how an FQHC or a health center can basically cull from the tenants there, learn about the different cultural diversity in the community, and what to do with that. So her name is Elena Cruz, and she's with us. I wanted to just go through some basic slides. Here, the next slide is about La Maestra. It talks about our mission, and I believe that since La Maestra did not start as a health center, but started as a nonprofit educational, community-based, grassroots organization, that's why there are many other services that La Maestra and the board really feel are important to expand on and add, so that there's kind of an integrated approach to wellness. It's not just a trip to the doctor today, but it has a lot more to do with incorporating and addressing the social determinants of health. So you will see that as we progress through the slides. To give you a little background, in 1986 we started with 12,000 students as a teaching vocational training, English as a second language. We had family literacy, we had a preschool, lots of services, mostly education-based and some health education. And then we started to see a lot of the gaps in healthcare delivery to underserved populations when we would see examples in our preschool of domestic violence, malnutrition, needs for shelters, all kinds of concerns. And the student council of these 12,000 students said, what we really need here is we need cultural competent services in our community. So we started interviewing some doctors and started 2 half-days a week and doing peds, and then quickly grew to OB. And within 20 years, we were providing 80,000 patient visits a year, and that's now, of course, grown over 24 years to about 30,000 patient visits, or actually now it's projected 177. That's what they came up with. So anyway, it just shows, I think, the need of so many people that are in our communities that sometimes we don't see if we're living in other areas or if we are occupied elsewhere. It's amazing how many providers have come to La Maestra, and interns and residents and professors and so forth, and they're like, gosh, we never knew in San Diego, this beautiful, tourist town and whatever, that, that there are these neighborhoods that have such incredible basic needs. People don't have enough food, the housing is horrible, the crime is, really prevalent amongst, the refugees, the immigrants, and the aged. So if you get somebody who's senior and they're in one of these units and they happen to be a refugee, it's really challenging. So anyway, that's kind of what we realized, and we started the clinic in 1990, and quickly we grew those services. So many of the job training, economic development, social determinants of health kinds of programs we've kept and we've expanded, and many we've added, which you will see on the slide here, which says Circle of Care. And by color, these services are grouped. So all of the medical services are red, and you can see it's pretty comprehensive in that we have medical services, dental, mental health, we call family wellness unit, we have radiology, and then there's some specialty services, tucked in there, as well as telemedicine and so forth. It's amazing how many patients will come in, or potential patients will come in after they've already had access to, let's say they first found about us through the microcredit or through our transitional housing or the legal advocacy services, and then they find out about the clinic. So that's what wellness is to us. It's like providing the basic survival needs, or at least a link to them, and then people learn how to access those services themselves, and pretty soon they're not survivors anymore, they're thrivers. So that's kind of the philosophy about La Maestra and how we choose which programs to expand on and which ones to develop is, the needs that we see in the community. We are definitely, we've always had a niche in being culturally diverse from the beginning, and that's because the staff and the board and everybody is representative of those populations that we serve. So the slide that says serving the culturally diverse community, we have over 26 languages and dialects spoken by staff. 80% of the patients prefer to communicate in a language other than English. And this is a little tip here. as a healthcare provider, there's a question usually on the EHR or on any registration that says, you know, do you speak English? Well, a lot of people will say yes, even if they don't really fluently, because for one, they don't want to, they don't want to seem stupid. They don't want to seem like they can't speak the language. But even if they have some low literacy in English, still, when you go to the doctor, when they go to the doctor, they're taking their kids to the doctor, they're nervous, whatever, they really would prefer, because they would understand better how, you know, about the treatment and the diagnosis and so forth, and of course the health education, they would prefer to communicate in their own language. So it's basically how you capture that information on your registration form, whether it's through EHR or manual, whatever. It's important how you ask the question as an FQHC or a community-based organization to be able to really understand the need for linguistic competency. And somebody asked me the other day, we were doing a tour for some nursing students, and they said, well, what's the difference between linguistic and cultural competency? And, you know, really linguistic obviously is just the language you're translating, but you're not being able to convey any of the cultural norms, which could greatly affect the treatment and the compliance, if you want to call it that, of the patients. Compliance meaning, you know, not that they don't want to follow or they don't want to take the advice, but it's more like they come back and you find out that really that they haven't taken the medication, and as a provider you don't understand why, and then you start asking more questions, and somebody of their culture would maybe tell you, if they had a good relationship with you, well, you know what, our culture doesn't believe that that medication is good, or it's going to harm us when we're pregnant, or whatever. So it's super important to understand the cultural beliefs and the perceptions, because it can totally affect the delivery of health care. And Elena was going to say something on that.
I just wanted to add that sometimes the patient comes in, depending on what culture they're from, they'll tell you, I have a headache, when actually it's not a headache. What the problem is, they're depressed, and they think that depression is in the head. It's another problem that they have. And unless you understand that culture, then you're not going to treat the problem. The problem is probably some kind of mental health problem that needs to be addressed. But because all they're saying is a headache, we're going to be dealing with a headache. So that's what I wanted to add in that one.
Thank you very much, and that's so true. And each one of the cultures has a certain background. Maybe some of them have been, you know, in refugee camps for, gosh, 17 years. Maybe some of them were born there. And so there's going to be inherent health issues that come along with different populations that might not be there with others that maybe had different background. So that's super important. One of the models that La Maestra has developed, and we knew this like from the beginning, was this medically trained cultural liaison program. We'll be talking a little bit more about that, because here in San Diego, when the voluntary organizations like Catholic Charities, International Rescue Committee, Jewish Family Services, were bringing over refugees and settling them in our communities, you know, nobody really knew from a provider standpoint who it was that was coming, what was, you know, what was different about them, how we would have to tailor our health education materials or our approach based on their culture. So quickly we had to, you know, to figure out how to be able to be aware of the needs of these new populations that are with us, and how we could do that and incorporate them into our circle of care and our FQHC. So that leads us to, how do you go out? How do you find how do you find these communities, where they are, where they live? How can you figure out in that population who there has had previous experience, maybe working in the refugee camps, or working, in their own country in a hospital or something that could perhaps help us be a liaison between that population, that culture, and our organization, and to eventually be able to train the identified people from those communities that also are interested, of course, in learning about more health care and eligibility here and so forth. And then eventually we will hire them. So part of that is using our staff that are out there in the field all the time, and Elena is an example. She is always out at the public housing, the low-income housing projects, and delivering information such as, anxiety, depression, and so forth. I'll let her speak a little bit about that, and then we'll get back to how do you approach other kinds of ethnic-based organizations to get that staff that you need to add to your FQHC.
One of the things that La Maestra does is we recognize that we can't learn everything from our patients, because when they're coming, we're dealing with communities that as Zara said, had been in refugee camps for many, many years. Let's take the Hmong refugees who no one even knew they existed. They were at the Wat Tam campus at that church, and for about 20 years no one knew there were these refugees, and all of a sudden they're ending up in San Diego. Well, they are illiterate. They don't know about health care. They have been moved from a compound to a city like San Diego. So there are so many things going on. And so because we hold health fairs, mini health fairs at public housing, at low-income housing, and they come, then we listen to different things. We look at what their curiosities are, and we try to find out what is going on, what type of health services do they need, and what's the barrier, what barriers do they have for accessing these health services. So that's one of the things. We find out from them that what normally people would look at, they would look probably at people who are highly literate, who are highly educated, who speak well, but these don't really know what the problems are. We need to find out where these communities congregate, what is dynamic of their families. So we need to partner with people that have started some type of relationship with them. I'll give you an example. The Hmong community, which is the one that I was talking about. The elders are the decision makers. Even though they may not speak a word of English, they may not understand the health care in this country, but they are the ones who make the decision. And we have to find a way. How do we get their trust so that they can tell us what we need to know so that we can help their communities? One of the things that we found out was that 80% of this population started, even at the age of 9, 10, 11 years old, with tobacco and alcohol, which is accepted in their community. But how do we find education for them? How do we find programs that will help them? By doing these mini health fairs in the senior income housing, we find out not only that, but we also find out the education that we're going to need for them towards their aging. We find that they come with all these ideas of we are going to work, but we're going to work only to have X number of dollars so that we don't lose our public assistance. But what happens when they age? They will not have built enough points in their Social Security system. This is when they really need it. So these are some of the things that we work with. Thank you.
Thank you. And to add to that, similarly, the Burmese, who actually with us, this is the latest population that have come, again, while they have some leaders in their community that are extremely motivated to form an infrastructure for their own ethnic-based community, they don't know how to address these issues that they see occurring in the population. Not just like what Elena says, what they come over with, the perceptions, the healthcare issues, what's accepted in terms of drinking and smoking in their community and ages, but also now that they've been here for a while, the leaders of their community are extremely concerned with the gambling issues. Mm-hmm. And so, and it just is out of control. And so that's one of the issues that they have spoken to us about in terms of providing classes, resources for counseling, for support, and similar to AA programs and NA programs, Gamblers Anonymous programs. But again, finding the access for that population to hook in to services that are already available. So, it might seem overwhelming, but if you look at how we have identified, we meaning all the FQHCs and community health centers across the nation, how we've been able to look out and see, okay, who's coming in the door? Who is in our community? How do we know that? Is it through services we provide at the school? Is it through services that we provide in conjunction with the faith-based organizations? Then you can start seeing, okay, for example, we had a lot of veterans that ended up in our community of City Heights. And again, they have need of basic services. These were veterans that did not obtain benefits through the VA hospital or the system. So we had to figure out, okay, how do we reach out to them? How do we tell them about the services and so forth? Well, it was by hiring veterans that had been through that had a good way of explaining what services we have, of leading them in, facilitating, making the process a seamless process because they already have enough challenges that they're facing. Another similar population or special population for us were people that were just getting out of prison, and there are going to be more and more that the state of California is releasing in large numbers, and they have already identified that San Diego is where they're coming. We've had this before a year ago, and we're like 4,000 that were all of a sudden in our communities. Again, these folks needed dental work, medical, counseling, transitional housing. They needed to get some job skills, and all of that was part of their wellness and mainstreaming, entering into society, starting new. So it's very similar with the refugees, the immigrants, whether they're migrant workers that are now moving into the city, or they're migrant workers that don't want to be out there in the fields anymore, they want to seek education, or whatever it might be. These are all special populations. So a lot of the approach is by, again, identifying, going back to this enhancing cultural competency, knowing who they are, the populations that perhaps are not having the same access as your normal patients, or a lot of them don't access services. They are just depending on their traditional medicines, and sometimes that's just not enough. So we do need to make sure that to reach out to all of them. And getting back to you know, the partners, how to identify partners, that would be, again, when you see patients coming in from these different populations that you want to reach out to and invite their community and do some health education and find people of their community that could potentially work with you after you train them. Those would be, these organizations are, you know, community-based organizations or, and I should say, faith-based organizations. Look for the temples. Look for the churches that are welcoming and incorporating different populations. For example, the church that John Queck belongs to, they have their services, 2 during the day, and then they told the Sudanese American community, you know, you can use our, this church is yours, and you can have your service here in the afternoon at this time, and you can have your youth groups meet here and your women's support services here, and that's basically what's happened. So that community, the Sudanese community, has grown up around this faith-based organization, even though their ethnic group has formed the Sudanese American Association that is separate from the church. Facility-wise, location-wise, it seems like it's together. So that needs to be included in the presentation, in the message that's delivered to the group. Like Elena said, there's some communities, some populations, you have to approach the elders first. Once you get their buy-in, then you can go freely into the community. The people will listen. They will receive the message, and they will take you up on the offer to go for dental, go for medical, go for mammo, whatever. Again, it's super important. There are a couple of examples I would like to leave you with. When we had a large group of Ethiopian that were settled here, gosh, years ago, we thought, okay, well, we have diabetes care outreach folks that go into the Latino population and the Somali and so forth. Let's go ahead and see if we can identify the Ethiopian, through the Ethiopian community, a few workers who would like to help us out. You know, we could train them for health education. Maybe they've had some background. We then put them through, you know, as we do all of our other medically trained cultural liaisons, we put them through basic training on confidentiality, HIPAA, all of that good stuff, and have them part of the staff so that when we are asking them to give us information about their culture or us to them, then they're able to understand that they're like a conduit. The information flows both ways, and they have to learn how to translate exactly and so forth. Well, anyway, we thought, well, we'll just go ahead and follow this model here, and we did. We got some great people from the Ethiopian communities, different tribes, and we started training them on health education and so forth, and they helped us in the exam rooms, helped signed up people for eligibility for different public programs and so forth, and all of a sudden we figure out through them that their community believed that the test for diabetes is what actually gives somebody the illness. So obviously we had to change that approach and then address that perception first in all of the presentations to try to provide that education. So you can imagine if we had not known that, we would have been just out there talking with no results. So it's really important to always monitor, you know, so okay, so now you've trained some folks from this new community that you've identified or a population that lives in your catchment area, and they're working with you, and so what kind of results are they seeing? What kind of patients are they bringing in? I mean, is there some follow-through here? And then, of course, how does that facilitate making appointments with, maybe perhaps transportation of some kind? A lot of times your collaborative partners that are either faith-based or community-based will have vans, like the Sudanese. They were able to find grants to purchase some old vans, and so that facilitates bringing their seniors, their youth to these different services. The roles of each partner, the community-based organizations and faith-based organizations help the health center because they help us identify, recruit, and train cultural liaisons. And why do we say medically trained cultural liaisons? Because unless they have some basic understanding about medical, whether we train them or they've been to a school, or perhaps they were assisting, the Red Cross medical team that served their refugee camp, they need to have some basic understanding. Otherwise, you might get into problems of, giving medical advice when they shouldn't, breaching confidentiality, all kinds of things. So they have to be given training. And they live back with, of course, their population, their community. So we've seen a lot of examples that the patients will call their neighbor, who's one of our cultural liaisons, and they'll say, okay, well, I need your help because I think I need to go to the hospital. And so they're basically having to deal with these issues like at 2 o'clock in the morning. But these are very committed, dedicated people that are representing their community, and they want to help so much, and they really give of themselves, more than 100%. They're fantastic. And they've educated our providers, our medical staff, our support staff, the nurses, to the point that, we just couldn't do it without them. And they are really an integrated part of our team in every approach, whether we're at the schools, we're, doing eligibility out there in front of Walmart, doesn't matter. They're there with us. Elena, did you want to say something?
I just wanted to bring out a couple of points about going to senior housing to do programs on site of them. One of the things we found out is why they were going to the emergency room so often. Then we found out that it was coming down to nutrition, because they hadn't worked enough time, and what they were receiving was SSI. They didn't have enough money for food, so some of them were buying a can of chili beans, and having it as 2 meals. Then they weren't eating properly. They weren't getting their medication properly. So whenever something happened, it was emergency room rather than going to their doctor, because they didn't have the money for the transportation. They didn't know how to access transportation for that particular community. So I think going to the places and doing a lot of health education on site helps a lot. And I think that's where we have been very, very successful, is identifying where to do the education, not only how to do it, but where to do it.
And like Elena said, that increases the probability that your team will reach out and touch more and more of populations that are in need and underserved and not yet connected to their medical home. They can access this care through all of these different health fairs or on-site visits, through the classes or workshops or whatever, presentations through the public housing, senior housing, low-income housing, schools, whatever. That's just so important. And then there's other information you'll find out too out there because they'll get to know you and trust you, and all of a sudden you find out that, okay, there's a couple, there's an old couple, and they're basically sharing, you know, they're both diabetic and they're sharing the needles, you know, or they're sharing the strips or their medication because they can't afford to both have their own set. And that's what you find out. You also find out about, you know, adult protective service issues and working with them as well. And again, it all has the basic component of that these populations come from culturally diverse backgrounds. And so they're going to address issues differently. And to us, we have to understand that. Another example was a case for outreach. We have 17 other SQHCs in San Diego County, Imperial County, and one of the oldest health centers decided that they were now going to go and do outreach in the Somali community. So they went and they took a big white van and they parked it in a park next to the low-income housing, you know, public housing that a lot of the Somalis were in. And they just went there and they put up a sign saying free HIV screening. And they were really surprised why they did not get one Somali to walk up into that van. And, you know, it's such a good example of not being aware, not taking the time to understand the community. One, the Somalis are never going to, they are not going to go into a large vehicle because in their country, large vehicles belong to the government. And the government's the one that came and killed how many of their families. So they're not going to just walk into a big white vehicle. It's like a big van, mobile coach. And two, there was nobody doing outreach to them to say, hey, you know, we're going to be here. This is who we are. These are the services we provide. We really want to invite you, your community, to attend. And is there somebody in your community that we can talk to explain this, to see if it's okay if we're going to do some screenings and so forth? Nobody did any of that work. And then the third one is that if they had bothered to find out, they would know that Somali are not, like many other cultures, are not going to openly walk in to a place that has a big sign about HIV testing with the whole community watching them. Like, you know, okay, so what were you doing that you think you're going to have HIV? I mean, there was a lot of social implications with that. And they're very clannish, very community, they're tight community, and they don't want anybody talking and seeing what they're doing, you know, even if there's nothing wrong. They don't want to, there's cultural stigmas about HIV testing and lifestyles, just like there is about mental health, behavioral health issues. That's why we don't call our unit mental health. We call it family wellness unit. So, and try to integrate it as much as possible, or a lot of our populations won't even, they're not going to go to that service because they are not crazy. They don't want anybody to think they're crazy. So there's a lot of work we still have to do around that. Let's see here. Languages spoken by staff. You see that list gives you an idea of, you know, the incredible diversity on our staff, and we use these medically trained cultural liaisons. We cross-train them, so they are also certified assisters. They are also front office. Perhaps they man one of the call stations, call centers. People are calling in with need for appointments and so forth. Maybe they work in referrals. Maybe they work in medical records. Maybe they're on the health education team. So the more we can cross-train these workers, the more incredibly invaluable they become. Because as our patients travel through our different departments, accessing services, then you know that you're going to have somebody that can communicate with them and hear back from them about information that's going to affect their, they're becoming healthy, they're following what the doctor's recommending or not. I mean, you're going to have to know about this, and that's going to affect your HEDIS scores, and and working with the managed care plans probably that a lot of the FQHCs across the nation are seeing more and more pop up. It's really incredible. We do a lot of cross-cultural orientation with the managed care plans so that they can understand even how to communicate with their members. And then when we send people to specialists, that's why we started with the telemedicine 9 years ago, because a lot of times the specialists aren't going to take people, for one, with that kind of payer source, but for two, they would if they could stay in their office in La Jolla, which is a nice place in San Diego, and the patients stay in our health center in their community with the translation, with the chart, with the information, with the provider, and they just communicate over this 15-minute time slot for telemedicine. So that is something that we really need to enhance and really expand upon, because that's one of the ways that we are going to continue to be culturally competent with our patients that seem to never finish coming in from other countries. Iraq is another one. There's another 30,000 on their way. So, and then knowing the nuances and the differences with treating Chaldeans who are Christian Iraqi versus the Muslim Iraqis versus the John the Baptist Iraqis, that's what they call themselves, versus the Kurds that were nomadic people and the Afghani and the Pakistani that are out there. So it's really super important for us, and so those also are things that we wanted to share. Let's see, John Queck, he's not here, but he, his passion was really and is helping his community with mental health, specifically depression, anxiety, post-traumatic shock syndrome, just being able to get by with or get through and survive with these images of the genocide that's happened with their community, as many others. So, he's committed himself to this. He's very passionate about it. He's very involved with the church. There's a Christian, I think it's Evangelical Church or Lutheran, and they are helping, of course, sponsor some of these programs for the youth and so forth. And it's admirable to see how all of our cultural liaisons, no matter where they start working with us. John started working in our job placement, our job training program as an assessment counselor, and then he quickly told us about, hey, he had worked in the camps, and he actually got a nursing certificate in the refugee camps. He'd been in 3 and so forth, but his passion was mental health. And we'd had cases that we'd found out through taxi drivers that were Sudanese that had told us that they were called upon by, by somebody at the county or something, because they said, oh, well, we understand that you speak, whatever the language is there of the tribe. And by the way, we have somebody that we think is of your community that we've had for 3 weeks inpatient mental health. And nobody could communicate with this girl. So finally, through this taxi driver, they finally found out, okay, she was of the Sudanese population, she was not Ethiopian, and they finally found somebody that could communicate with her and found that she was schizophrenic and so forth. But can you imagine 3 weeks basically put in a hospital away from the family and everything, and nobody could even communicate with this girl? So those are some of the really incredible needs of why we need to address these populations that live in our community. Okay, so Elena, would you like to add anything else?
Well, I'd just like to talk about a program that the maestra has that I think is a great help to any community. We have a microcredit program that works with women only, and it's giving out small loans for them to start a business. I think that one of the things that it does, it helps them to get some dignity back, because no one will lend them because they don't either they don't have a job or they're not bankable. But with us lending them money, we're saying we trust you. And what happens is we meet in groups. We meet once a week, and for me, this is a platform where a lot of the problems in the community come out, and it helps us to address those problems. A lot of them are problems either of health or mental health, and if we don't know about it, we can't address it. And then if we cannot address it, how can we have a healthy community? So I think that this is a program that brings us information, and for us to give them solutions. That if you want to know more about it, you can either give me a call or call Zara, and she'll let you know more about it.
Well, thank you for that teaser, Elena. That was great. Now, thank you all for listening, and if there's any questions, we'll be happy to answer them.
Great. Thank you so much, Zara and Elena, for your presentation. We will go ahead and open up the Q&A portion. Do you have a slide with some of your contact information for people who are on the webinar?
Do we have what?
A slide? No, we don't.
Oh, sorry,
Okay.
we do not.
Okay, that's fine. I can actually, if you don't mind, when I send out the PowerPoint to all of our attendees, I can include that information of ways that they can get directly in contact with Maestra. So just for a few announcements, while I'm waiting for questions to fill up in the queue, if you do want to ask a question, please type it into your chat box. It should be right there to your right in your toolbar, and we'll go ahead and get those questions over to Zara and Elena. For more information on who we are and some of the services that we provide, please feel free to contact us or visit our website at nchph.org. We have information about webinars and one-on-one assistance and other ways we help community health centers serve their special populations. Also, consider joining our mailing list to receive updates from HRSA and funding opportunities, as well as the release of important resources and documents. And of course, we're on social media, so you should follow us at NCHPH.org. Even through this webinar, I was tweeting some of the things that Zara and Alina were saying, and so we put a lot of information out there and want to interact with you through social media as well. Also, I hope you guys all plan to attend the 2014 Health Center and Public Housing National Symposium. It's taking place in June 10th through the 12th in Alexandria, Virginia. And if you check our website at nchph.org, you'll find more information as well as the registration link and site. Here is our contact information. Please feel free to contact anyone listed here. These are all the staff members for the Health Division, and we look forward to assisting you in any way possible. I will go ahead and open up the Q&A portion. So I know Alina gave us, as Zara said, that teaser, but someone wanted to know, what are some of the challenges that you at La Maestra have faced with social justice or women's health and religion?
Religion, I don't think we have. One of the things that I do is I say we don't talk about politics or religion in our groups, but social justice we do. And that's one of the reasons that we have this microcredit program, because if there's no social justice, there is no economic justice. And we belong to the Microfinance Alliance, and we have a yearly conference here in San Diego. And we look at all the things that we've we've had throughout the year, and we try to address them. We think that with doing the loans helps in a lot of way in the social justice, because one of the components in the microcredit program that we have is savings. And at the end of every loan, there's a savings of $125. With the first loan, we require that with those savings, they open a bank account, which makes them bankable. So we've taken down one of the barriers in their assessing a loan from a bank, because now they're bankable. Now they can see that they are able to not only have a checking account, but a savings account. And when they need something from the bank, they can now go to the bank and get a loan.
Sure, and they've now started building their credit and so forth. I mean, and I think we should clarify that the loans we're talking about are like $250, and then they have to repay that at like $19 a week or something. And one of the requirements, which I think is the best part of this, is that they have to come for these support groups every week to talk about financial literacy, to talk about why it's important to have a credit, you know, a good credit. And then they'll talk about issues, a lot of times health-related and social service-related, that will affect how they are able to grow their business or not grow their business according to the business plan that we help them develop.
One of the things that we have found out in these groups is that the domestic violence, how big it is in the community. And so we developed a financial literacy program for domestic violence victims. And we bring in a lawyer that talks to them at the end of the program and offers free services to them.
Excellent. Excellent. Someone wants to know, how can you train your staff when you see so many different patients? Like, what tips can you provide to a health center that has this great diversity? How do you train your staff?
One topic at a time. Yeah, we have a lot of provider meetings, we have coordinator meetings, we have, you know, department meetings, and we have specific curriculum that we have developed for the last 30 years, even when we were back in the educational program, on how do you incorporate and really, you know, stress all this cultural competency.
I want to say one thing that happened to me when I first came to work at La Maestra in 2005. We're having a new wave of refugees come in, and Zara called a staff meeting, and she called a meeting of everyone who worked at La Maestra and talked about the new refugees, talked about the things that these refugees were bringing that were unique to them. So even before we started seeing these new refugees as patients, we knew about them, and we knew what were some of the things that were different so that we could avoid those things. I think that's one of the first things in the training, and not only of the ones who are going to be working mostly with that type of population, but for all of us, so that we knew what to avoid, even if we just saw them in the hallways.
Yeah, like some of them, like, for example, if you see these adorable kids, you don't pat them on the top of the head, for example, with a lot of the Asians. And, you know, or taking pictures, and, you know, a lot of issues like that. But it is possible. It is possible. You just go one step at a time.
Wow. Oh, excellent. Okay, and do you offer any referral sources for human trafficking and worker justice issues?
Yes, actually, La Maestra, Elena and I are laughing as man. It's a huge issue for us here on the border, and we have this map that shows how many human traffic victims we've worked with, and there's like 30 countries already. It's amazing. And they're both labor traffic, sex traffic victims. We're the only FQHC community health center in San Diego that has a relationship with the Office of Refugee Resettlement, a contract. So if they get contacted back in D.C. through Homeland Security, whatever, about certain issues that are happening here, all of those cases get referred to us. And a lot of times our staff is involved in those sting operations.
Mm-hmm.
Unbelievable, because they have to be there for the victim right away.
Yeah. Wow, that's amazing.
Yeah, we never figured on that, but yeah, there we are.
Okay, that might be for another webinar. We might have to get you to come back to speak on the sex trafficking and human trafficking issue.
Yeah, and the labor traffic is huge. I mean, I'm sure there's many more cases in each state that, you know, folks just don't realize, and these people aren't going to say anything because, you know, who's going to help them?
Yeah. Oh, yeah. Just quickly, as we're kind of winding down, how do you form these partnerships with faith-based organizations? Is it just out of goodwill that they assist you or participate with the programs and services you offer, or do you offer these organizations something in return?
Well, what we offer them is, you know, ability for their what do you call it? Yeah, not their parish or their congregation to access services that they see that they need. And then another thing is that, you know, we've had a food pantry here for over 10 years. So we can then tell the you know, the different faith-based, look, you know, we'll be happy to come and do you know, come and bring food if you have an activity going on or whatnot. You know, we'll see how we can partner.
Excellent.
But most of all, it's because they're interested in helping their congregation.
Yeah, which is really good with the faith-based, using faith-based organizations to reach your community. And then, of course, you know, the question that everyone wants to know is, how do you fund these? Are these reimbursable by Medicare or Medicaid, or are you using grant funds?
Well, the answer is nobody. Okay, nobody. But look at it this way. One, it's, you know, it's the right thing to do. You know, you want to help the underserved, and you know, that's the mission. And you also need to sustain your business. I understand that. So if you can look at this way, a lot of the refugees and the diverse populations are covered through Medicare, through whatever managed care plan is there. For us, it's like Medi-Cal, our version of the Medicaid dollars, plus it would be the managed care plan. And so you would get reimbursed for those services. You add new patients, you add more visits, and, you know, you're doing a good thing. So that's where you get that from. Also, you can negotiate with those managed care plans like we have and said, look, these folks need to understand that are coming in a lot of stuff that you're not able to teach them, like what is even managed care? How do I navigate through our, you know, through this plan? I mean, where am I supposed to go and all of that? So if the health center takes on part of that health education, then you could get, you know, like $30 per health education that's outside your cap with that managed care plan, because they know they need to communicate with their members, and they're not, because they don't have the staff with the you know, cultural competency that we do, clearly. So you just got to build it.
Yeah. Oh, yeah. Well, once again, I just want to thank you both for participating in today's webinar. We will release these resources very shortly to all who attended the webinar and registered for it, and it will also be made available on our website. So thank you again, and look forward to seeing you in Alexandria this June.
Okay, thank you very much.
All right, bye.
Bye. Bye.